Hey everybody, really fast, let's go through the pathology of shock. So, to just boil it all down, shock is the state of systemic tissue hypoperfusion. So, there's not enough blood going to basically everywhere. And it could be due to the reduced cardiac output, circulating blood volume, but ultimately it leads to the hypoxic tissue injury. We'll get through the types in like the next slide, but there's going to be the resistance to flow, cardiac output goes down. It could be due to heart attack, weak contractions, less stroke volume, but like all in all, shock, no blood flow. Okay, so let's go to the types. Sorry. The cardiogenic is going to be a low cardiac output due to a myocardial pump failure. So it's the failure of the heart itself. It's going to be characterized by hypotension, tachycardia, weak, thready pulse is important, and it's very cool, pale, moist skin. So this is also a really important diagnostic feature. There's crackles, tachypnea, increased systemic vascular resistance. So this is going to be this is going to be due to the compensation, right? So because of the decreased cardiac output, the body's still going to try to compensate by increasing the vasoconstriction. So it can be due to any of these. They're all really important, like very deadly. Hypovolemic is going to be due to low blood volume. It's going to be characterized by hypotension again, tachycardia, weak, thready pulse, cool, pale, moist skin, and there's also going to be increased stroke or systemic vascular resistance as the compensation. So it could be due to hemorrhage, diarrhea, vomiting, and burns. Burns are the ones you have to pay attention to because it can also cause septic shock. So mostly it's caused by gram-negative bacteria, but can be due to all these other factors. And this is different because this is going to be characterized by pink, warm, and flushed skin, and it's going to be both decreased cardiac output and decreased systemic vascular resistance. So this is very dangerous because you're having no compensation. Neurogenic is going to be due to spinal cord trauma. It's going to be characterized by hypotension again, bradycardia instead, and warm, dry skin. There's going to be decreased cardiac output again due to the bradycardia, along with venous and arterial dilation. And there's going to be loss of sympathetic tone. That's causing the dilation. There is no compensation either. Anaphylactic shock is due to a type 1 hypersensitivity, so this is an allergic reaction. It's going to be characterized by hypotension, tachycardia again, a cough, dyspnea, pruritus, so a rash, urticaria, this is going to be hives, restlessness, and decreased I'm not really sure what this is, but it's not that important. More importantly, there's going to be decreased systemic vascular resistance. There's going to be the opposite effects. So it's going to be vasoconstriction in the bronchioles, and there's going to be vascular dilation. So the stages. Non-progressive stage is when the BP is low and the skin is pale and cold. So the net effect to kind of compensate is going to be tachycardia, vasoconstriction, and the renal conservation of fluid. Extracellular damage occurs because of the lactic acid buildup for the vasoconstriction. The progressive stage is when the patient starts to have difficulty breathing and the heart's going to be even faster. Now there's going to be a lack of consciousness and a weak pulse due to the tissue hypoxia. In the irreversible is going to be end stage, right? So there's going to be organ failure, and the first to go are the kidneys. It's due to the lysosomal enzyme leakage, so there's going to be even more tissue damage along with the lactic acid buildup, and then with the extravasation, it can have a additional bacterial inflow into the blood due to extravasation from the intestines, right? So here are the stages again. The body's going to switch from aerobic to anaerobic. There's the lactic acid. Compensatory stage, catecholamine is going to increase, tachycardia is going to occur. Vasoconstriction, aldosterone is going to be increased to raise the blood pressure. It's going to decrease urine to retain the fluid, increase the heart rate, and increase the glucose level to meet the extra demands. In the progressive stage, here we go, there's going to be everything kind of catching up to you, right? So there's going to be metabolic acidosis from the kidneys failing, respiratory acidosis from the tachypnea, peripheral edema because of the aldosterone. There's going to be the irregular tachyarrhythmias thanks to all of the catecholamines released, hypotension because of the vasodilation and the cardiac failure, pallor, cool and clammy skin. That's going to be due to the decreased blood flow and altered state of consciousness because now it's going to be decreased blood flow to the brain. Refractory period is its end stage. Okay, so the morphology, the cells are going to be swollen, as you can see here in the tissue and in the kidneys. This is renal tubular necrosis. So they're starting to caseate, neutrophils are coming in. There is going to be ischemic encephalopathy in the brain, coagulative necrosis in the kidneys, and the liver, in the pancreas, in the kidneys in particular is the acute tubular necrosis. The epithelial cells are going to be necrotic. There's alveolar damage. So thanks to the rapid breathing, there's going to be the alveolar collapse, while some are distended. And then the cells are going to be desquamated. It can be caused by acute adrenocortical insufficiency, where the adrenal gland is going to be necrotic, and that's in the Waterhouse-Friderichsen syndrome, in the fulminant meningococcyemia. So it's a meningitis, and it enters usually the meninges, it spreads. That's the fulminant definition, right? So it first enters the CSF, and then now it's full-on septic. That's when the blood vessels in the adrenal glands rupture thanks to severe bacterial infection, and then it's an adrenal crisis because the adrenal glands stop producing the hormones, so it's adrenocortical insufficiency. Important ones we need to be worried about is going to be the aldosterone, so there's not going to be any fluid retention, or there's not going to be any salt retention. Cortisol, so there's not going to be any catecholamines being activated. And then the androgens, not as important, but the first two hormones, very important. So it can also be caused by Neisseria meningitidis, which is carried by mosquitoes, and it's pretty common in infants, so important to manage. From the gastrointestinal tract, there could be patchy mucosal hemorrhage. Okay, so back to septic shock. One of the only ones that are warm shock. The other one is the neurogenic shock. So there's going to be high cardiac output, but low peripheral venous return. So there's going to be vasodilation after the collapse of all the constricting factors that leads to the vascular leakage and then tissue edema. And then it's caused by the microorganisms, gram-positives, common cause. Endotoxins are going to be the main signal, and that signals the complement cascade to be activated. So in phase 1, it's going to be good first. The Kupffer cells in the lower intestines are going to release the inflammatory signals because you're saying, hey, something's wrong here, bacteria has escaped. Phase 2, alpha toxin induced pathological response is going to occur. It's going to have more platelets aggregate, which is not necessarily a good thing because too much aggregation is going to lead to ischemia because the capillaries are really small, remember? So the inflammatory cytokines are going to be released by either like the antigen presenting cells or the platelets in response to the toxin. And remember, there's going to be a lot of platelets aggregating. So each platelet is going to release a lot. And then now that a lot more have been recruited, there's going to be a huge amplification of the cytokines. And they diversify the response and make the shock like worse. Arachidonic acid is going to be converted to prostaglandins, and that's also going to make the vasodilation increased. This is going to lead to the adult respiratory distress syndrome in the lungs, and then the coagulation factors, interleukin 6 and other mediators, are going to promote the intravascular coagulation, increasing the platelets, increasing the inflammatory cytokine response, making more arachidonic acid, making more prostaglandins, leading to the worsening of ARDS. So on top of all of that, thanks to all these coagulating factors, there's also going to be the activation of the clotting pathways. So now this patient is going to be, there's going to be bronchial constriction, there is going to be inflammation, and there's now going to be thrombi forming. So TNF, interleukins, and the catecholamines are going to suppress the insulin response, so the platelets can have all of the glucose in order to continue this cascade. And the patient now, on top of all of that, has hyperglycemia. So shock is very hard to treat, and it all happens incredibly fast. Okay, so toxic shock syndrome is going to be a microbial exotoxin, and it works as a super antigen. What's a super antigen? Super antigen can bind to several immunoglobulins, activating a lot of B cells, which produce a lot of cytokines, basically it. So as you can see, they can activate both like TLR2 and TLR4. Also, and that will combine, that will activate TCR-HLA2, and then that's going to release a lot of factors. So the danger is going to be the hypotension, the hypoxic tissue damage, and cardiovascular failure. How do we treat it? So in septic shock, you give the TNF alpha, interleukin 10, 4, and 3 to control the amount of recruitment of the immune system. So we're going to give these to stop recruiting the B cells from making antibodies, and you're going to stop the T helper cells from activating more B helper cells. So we're giving this to stop the cascade in whatever step, right? You don't give the IV fluids because that can worsen the cardiogenic shock, and that will worsen the pulmonary edema. You have to put all the patients on ventilation. So in general, patients are going to be kept in the cold because too warm is going to increase sweating, and that can lead to the hypovolemia. That's going to worsen the shock, so important. You're going to put the patient in a Trendelenburg position, so you can help the heart out a little bit by increasing the venous return. And the replacement therapy, you're going to give them whole blood or plasma or dextran, not IV fluids, all right? You'll kill your patient if you give them IV fluids. And plus, they're losing a lot of blood and, platelet and activating factors and whatnot, thanks to all of them being used up, right? So this is important. In the hypovolemic shock due to dehydration, so burns and whatnot, you want to give them a balanced electrolyte solution, in particular the Ringer lactate solution. You will give them the sympathomimetic drugs. Sorry, we already covered this in the anticholinergic drug in pharmacology lecture, but these are going to be helpful in the neurogenic and anaphylactic shock, because the sympathetic tone is either low and damaged, and the vasodilation is present. Dopamine is going to be used if epinephrine is not available, and norepinephrine can also be used, but the first line drug of choice, epinephrine. This is only in super, super rare cases. Epinephrine is available in most clinics and hospitals. Oxygen therapy, ventilation. Okay, so quick little lecture for now. Thank you for your attention and good luck studying.